So, hi, welcome to another SBQTalk. It's the official podcast from the Brazilian Hip Society. My name is Alexandre Pena, and we're here with Professor and my friend Joe Matta to talk about how is a total hip replacement in the other side of the world. Our main subject will be acetabular fractures. Should we fix or should we replace it? So, Dr. Matta, thank you very much for coming, and it's a pleasure. And we have lots of pictures.
Okay.
Let's start with the first question about when faced with an acetabular fracture, what are the main guiding for your choice between fixing or replacing?
I would point out at the beginning that if you see an acetabular fracture and you don't think you can get a good prognosis with fixing isn't enough. We need to reduce and fix. Everybody talks about fixation. Okay, you need to reduce and fix. Okay, so I heard a
That's an important point.
Yeah, I heard a talk on the sacrum fracture today, and all they talked about is how to fix. I didn't hear one word on how to reduce. And this is the most important point, because if you just fix a fracture, the acetabular fracture, the patient has the same problem after surgery as they had before surgery. They have a displaced acetabular fracture, okay?
Okay.
So the treatment is to reduce. Fixation is to maintain the reduction. The goal with the acetabular fracture is preferably to preserve a mobile, painless hip for the rest of the patient's life. So you think you can't do a good job operating, reducing, and fixing the acetabular fracture. That doesn't mean you can get a good result with a total hip, okay? It's not like the alternative, okay, we do reduction, fixation, or we do a total hip, because in order for the total hip to work, we need to have a stable acetabular bone on which to place the acetabular prosthesis. Now, I hear people talk about, well, you just put screws through the cup, and this is going to hold the acetabular fragments together.
You don't believe this?
Well, this is like I saw a Superman movie, and Superman was carrying Lois Lane through the air, and she said, "Who's holding you?" So the screws in the cup can't hold the cup to the bone, plus hold the bone to the cup. The main reason you have screw holes in an acetabular prosthesis is to secure it to a stable bone. And we know even when we do revision surgery and we have a big defect in the acetabulum, we can't put the cup in and, let's say, secure the bone graft to the acetabulum with screws through the cup. The bone graft has to be stable. The bone graft supports the cup. So the bone of the acetabulum, I think there's some fallacies, and I think we probably don't yet have a good implant for doing an acute total hip. We need some better type implant. There may be some coming out, but if you're going to do a primary total hip, you need to get a reduction and fixation of the acetabulum. And the reduction and fixation of the acetabulum is to hold the acetabular components. So it's a bigger procedure because you need to reduce and fix. So the times I've done this, I've done it through an anterior approach total hip. So typically it's been through the Smith-Peterson incision. Happily, one of the common fracture patterns that is in the older patient that you might consider a primary total hip is an anterior column or anterior wall plus posterior hemitransverse. And this can be addressed from anterior. We can place through the extension of the anterior approach for total hip, more like a complete Smith-Peterson incision. We can access the internal iliac fossa. We can place a plate on the pelvic brim to secure it. But there's other problems that can come up too, is that, let's say we put the plate on the pelvic brim, the plate buttresses the anterior column or the anterior wall. When you do the total hip, in combination with this, there's a tendency to devascularize the anterior wall particularly if it's a separate anterior wall piece, because we've done the approach to the inside of the bone, and now we're doing approach to the outside of the bone with a capsulotomy, or maybe even some surgeons do a capsulectomy. So what is the soft tissue pedicle left to the bone to make it vascularized? So I've seen, in my own cases, I've done primary total hip. I think I've seen a failure, and it was partly due to devascularization of the anterior wall.
Okay.
As it comes down to, for me, it's a select number of cases that I think you can do a primary total hip. Some other cases, maybe I'm not entirely happy what I could do with the open reduction internal fixation, but I do it first because I need to restore the bone. Or maybe the patient is treated non-operatively originally. So anyway, just some comments, but I don't think it's a solved problem where you have this treatment or that treatment. There's another group in there where probably neither treatment is going to
Solve the
work
problem.
well. Yeah, there's going to be difficulties with either one of those treatments.
Yeah, I completely agree. And maybe the most people who indicates total hips in acetabular fractures are the one that never did a total hip in an acetabular fracture. He look at a very bad fracture pattern and say, hey, no, put a total hip on it. It's a very difficult and complex surgery. Is much more complex sometimes than only fixing the acetabular fracture itself.
Yeah, and the issue is too that if you have a complex acetabular fracture, you do a primary total hip, and then the fracture displaces and the cup goes inside the pelvis, you have a much bigger problem. You have a very big problem because you've just trying to correct this non-union and bone defect with the total hip in place is a big problem.
It's a big problem. Let's move on. Here, it's a very interesting paper that you published some time ago with Tanya Ferguson about acetabular fracture in elderly people. I remember reading that.
Okay.
Right? Yeah?
Yeah.
You know, in elderly patients, do you find yourself learning more towards arthroplasty? Why and why not? I know the answer, but, you know, I have to ask you.
Well, I think I spoke about that already, and so probably the older patients, I think it's still a selected group. I'd consider the primary arthroplasty, but the main thing is that I need to be able to get a reduction and stabilization of the fracture in order to have a good place for the acetabular component and do the total hip.
Perfect. What about saying that the best tribology in the hip is cartilage on cartilage, much better than ceramics on ceramics or ceramics on polyethylene, right? If we can preserve, maybe, as you said, if we can preserve the bone, if we can achieve a good reduction, maybe the age is not an issue. Am I right on this thought?
Yes. The hip will work. I mean, the older patients, they don't have an impairment of healing. They heal the bone very well. The problem you're going to get is the problems increase with osteoporosis of the bone and also sometimes with impaction of the articular surface, which can happen in the osteoporotic bone.
In your long career as a hip surgeon, as a high-volume hip surgeon, can you share with us, with the Brazilian Society, a challenging case that taught you an important lesson in the decision-making process? Do you remember some particular case that helped you learn something?
Oh, yeah. I mean, there's always in many areas. And I think after I've done surgery for 45 years after my training, and you still learn. And you have to be ready to learn to rethink what you do, to modify your techniques. I don't know. I mean, difficult cases, certainly with the acetabular fractures, you know, at the beginning, you were open the bone, you had no idea how to reduce, or you had many random moves you would trying to get it reduced. And then finally you'd find something that worked. And with the greater experience and seeing the same fracture pattern again, at different times, you'd know how to begin the move. You'd know the order of fixation in order to move ahead with the procedure. And acetabular fractures are a difficult subject because sometimes when you get a case and you'd remember how you did it, the case before was 3-5 years ago that you saw this unique pattern or this unique problem. So the experience was there. There are some principles that have been established over a long time that still prevail today that I think people forget about is, for instance, with a both column fracture, which is common, ilioinguinal is most common, start with the anterior column first, and you need to reduce and fix it perfectly. I think it's a problem with the Stopa approach combined with the approach to the internal iliac fossa. I see many times they never get the anterior column reduced at the beginning, and the anterior column's tricky. You need to see the entire line, the internal iliac fossa, plus you need to go to the second window of ilioinguinal and get that reduced. We had the case bringing up this morning, principle when you have combined pelvic ring injuries, acetabular fracture, let's say an anterior ring injury with a symphysis, all this combined. Principle, you start at the posterior pelvic ring, reduce and fix that first. And that doesn't matter if the posterior pelvic ring injury is ipsilateral or contralateral to the acetabulum. If you have a left acetabular fracture and a right sacroiliac dislocation, you have to start with the right sacroiliac dislocation. Otherwise, you'll never get the acetabulum reduced. And the final step is to do the symphysis. And same with the pelvic ring injuries. Like I said, we talked a lot this morning about how to fix, the different ways to fix, but how do you reduce? Letournel's golden rule, reduce and fix the posterior pelvic ring first, then the anterior pelvic ring. Some of these simple principles, if you keep them in mind, it'll help quite a bit.
Cool. At least I was paying attention to the presentation. I was paying attention. I was there.
Oh, you were there. Okay. Thank you.
Do you foresee any changes in preferred approach for acetabular fracture over the next decade? Because, acetabular fractures are something that it's really difficult to learn. It's very demanding surgery. The approach is much, much more difficult. I remember when we used to have the Letournel course, so pelvic and acetabular course. Nowadays we have an anterior approach course, which is 1-day course. And a pelvic and acetabular course, it's 4 or 5 day course. And everybody, you don't leave the course saying, hey, I can do it. I can fix every acetabular fracture. What is your concern and any tips and tricks for people who will start this demanding procedure, start learning this very demanding procedure that is treating acetabular fractures?
I was asked this question maybe 20 years ago in Britain, what will be the next development? And to me, the answer I gave was education's most important because Letournel was doing acetabular fractures better 30 years ago than most people can do it today. So I think with acetabular fractures, it's going to be hard to get a lot of people or many people with enough experience to do it really well. It still needs to be taught the reduction fixation techniques, but maybe the protocol of Letournel, my protocol, maybe it's not the best going forward. It takes a lot of experience to learn, and we have to think too, we don't want to do harm to the patient. We don't want to do very big approaches and get bad reductions. So sometimes I think maybe a lesser approach with a slightly imperfect reduction is less harm for the patient. One of the, some of the principles from the beginning are to minimize soft tissue invasion. The orthopedic table is a big help in reduction, and that's one of the ways Letournel always minimized the approach. And I did too, is having the availability of the orthopedic table to avoid two approaches or extended iliofemoral approach. Fixation, sometimes I see plates all over the bone. Still not reduced, but there's plates all over the bone. So soft tissue damage should be minimized. Fixation, not overdone. And also there should be a eye toward being able to remove implants, because sometimes you get problems like infection. You need to remove the implants. Implants placed in young people in their 20s a lot of times need to come out later on. It's one thing I don't like about these plates that cover the whole quadrilateral surface, that are placed through scope approach. Yeah, they're almost impossible to remove, and you end up risking damage to the obturator nerve and artery when you try to take these out. So I don't think this is a good move, with the bigger implants like this. And another thing is that when I see these big plates, and I see the techniques that are used, surgeons are expecting that the implant reduces the fracture. What I've found over the years is that the plate does not reduce the fracture. This is, or tightening a screw that the lag screw pulls it. This doesn't happen.
Doesn't happen.
Yeah, you have to reduce the fracture first, then the fixation comes second. And usually after reduction of the fracture, another thing I'd say doesn't work is K-wires to hold it, okay? If you put in K-wires, you always see a little displacement. Something goes away again.
It's not strong enough, right?
Yeah, so you need a reduction. Then the best fixation is maybe with some lag screws or fixation screws initially, then a definitive plate reduction, then definitive plate fixation. But your implant doesn't reduce the fracture. You have to reduce the fracture first. The implant comes secondary. The implant shouldn't be much more than you need, and you should have an eye that you can also remove the implant at some point without endangering the soft tissues with dissection, And we talked about that. I've talked about that with one case this morning in the discussion. Even with the plate on the posterior column, the most distal part usually stops at the upper pole of the ischial tuberosity. I don't like to go down over the ischium, or it can be very hard to get out without injuring the sciatic nerve. And the plate shouldn't go too proximal up the ilium, or you can injure the superior gluteal nerve, and it's very difficult to get out again, if it goes through posterior parts too far up the ilium. Sometimes with the ilioinguinal approach, I don't place screws very close to the distal pectineal eminence. They can be very hard to get out later on. So you have to think of these things also.
So we have to have all those principles in mind and follow them.
Yes, I agree.
Hey, thank you for the interview to the SBQTalk show. It's a talk show, right? It's not all talk, it's a show. It's Joe Matta. Come on. Thank you very much, Professor. Thank you very much.
Okay, thank you, Alex. It's been a pleasure being here. I really feel very honored to be an honorary member of this society. Thank you.
Great. Thank you.